So as you guys know that today is our bootcamp session, we'll be revising each and everything. So first of all, we'll be starting with our first topic, that is knee. And you guys already know that you guys are going to participate in each and every topic, right? So like it's a kind of revision. So I'm expecting from you guys a lot, right? Can you guys just see my screen? Hello?
Yes, dog. Yeah, we can see.
Okay, that's perfect, right? So the first topic which we discussed was our knee, if you guys remember, right? So can you just please tell me that how much okay, we have four bones which are basically making your knee. Anyone who can just please turn on their mic and tell us something about the knee joint? It's
Yeah.
yes,
Hello.
yes, please.
Yes, the knee joint is composed of four bones: femur, tibia,
Perfect. Can you
and
please name that bones?
yes, the femur, tibia, fibula, and patella. And
Perfect.
there are four ligaments. Two of
Okay.
them is cruciate, the anterior
Mm-hmm.
cruciate ligament, and
Okay. We
posterior
discussed
cruciate
the word
ligament.
cruciate. What do we
Yeah,
mean? Okay.
cruciate means I think it's crossed over from the anterior to posterior.
Perfect.
Yeah, and
Okay.
the collateral. Yeah,
Okay. That's
the
perfect.
collateral or is the in the medial. It is the medial collateral ligament, and one of them is a lateral. Is the lateral collateral ligament.
Okay, that's perfect. So we were discussing about the knee joint. We discussed we have four bones inside the knee joint. We have our femur, which I have already illustrated here. We have our tibia, our fibula, and patella, a small bone. Right? We'll be discussing each one in detail. We discussed that we also have some ligaments there. We have cruciate ligaments. Cruciate are the cross kind of ligament that cross over one another. So we have anterior cruciate ligament and posterior cruciate ligament. Then we also have collateral ligament. On the medial side, we have medial collateral ligament and lateral collateral ligament. Okay. So we also have menisci, if you guys remember, two menisci, our medial menisci and lateral menisci. Remember? Hello?
Yes.
Okay. So we were discussing that we have, a protrusion kind of things present on your femur bone, which are known as condyle, right? And above those condyle, we have like small protrusions, which are known as epicondyle. We'll be discussing details like the insertion point of a lot of muscles and things, right? So we discussed this is our femur bone. We already know that. We have our patella, we have our tibia and fibula, right? So all of these four bones collectively make your knee joint, right? Okay. So can you guys just tell me something about the cruciate ligament? As we discussed, we have cruciate ligament that cross over one another. We have two types of cruciate ligament, two types, okay? So we have anterior cruciate ligament and posterior cruciate ligament. So anyone who can just tell me what's the function of anterior cruciate ligament?
Can I say?
Yes, please, definitely.
Yeah, the cruciate ligaments and anterior cruciate ligaments, it's just a prevent forward. The both ligaments, the function is prevent and forward and backward movement of the tibia.
Perfect. So in order to, limit the exaggerated forward movement of your tibia, anterior cruciate ligament helps in that, right? So anterior cruciate ligament basically comes from the posterior aspect of your femur. It attaches anteriorly to your tibia. And if I'm just pulling tibia, forward, right? So what happened? It would limit the motion. It would limit the exaggerated forward movement of your tibia. Is that clear? And another point which we discussed is the most commonly injured ligament in different sports. Is that clear?
Yes, sir.
Okay, perfect. We discussed posterior cruciate ligament as well. Can you just tell me the function of posterior cruciate ligament?
It prevents the overextension or backwards movement of your tibia, of your leg.
Perfect. So it prevents the exaggerated backward movement of your tibia. Like it comes from the back of your femur and attach at the back of your tibia. So if you're just moving tibia backward, so it would prevent the exaggerated backward movement, like it have held the tibia in place, right? So we have a UWorld MCQ on that. If you guys remember dashboard injury, can anyone just tell me what is dashboard injury?
During motor vehicle collisions.
Okay, so for example, if someone is sitting in car and his knee joint, strike the dashboard, what happens? We are going to see rupture or damage of posterior cruciate ligament. And the idea is so simple. If I'm just, putting force on tibia from the anterior aspect, so it would just move posteriorly. and all of that force would be experienced by your posterior cruciate ligament. And if the force exceeds the strength of posterior cruciate ligament, it would tear. Is that clear? Okay, perfect. Okay, so here you guys can see we have our patella bone. We'll be discussing that in detail. So, okay. So these are your cruciate ligament. You guys can see it just makes a cross, right? That's why they are known as like a cruciate ligament. This is your anterior cruciate ligament. If I'm just, moving forward your tibia, it would limit the motion of your tibia in forward direction. Which ligament? Anterior cruciate ligament. And it's a weak ligament, most commonly ruptured, right? Then we discussed we have posterior cruciate ligament. If I'm just moving back the tibia, so posterior cruciate ligament is going to limit that movement of tibia. Is that clear?
Yes,
Yes.
sir.
Yes.
Okay, perfect, right? So you guys can see here, these are your cruciate ligaments here in the imaging. This is your posterior cruciate ligament. You guys can clearly see, it comes from the back, attaches at the back of tibia. If I'm just moving tibia in this direction, it would limit the motion of your tibia, right? Similarly, you have anterior cruciate ligament coming from the back, attaching forward to the tibia. If I'm just moving it forward, it would limit like the forward motion of your tibia. Is that clear?
Yes.
Okay, we discussed we have collateral ligaments on the medial side and on the lateral side, right? So here you guys can see we have our medial collateral ligament and our lateral collateral ligament. We discussed that, for example, if someone is striking, let's suppose if we have a soccer player and another, another soccer player come and tackle and kick him at the lateral aspect of his knee. So it's obvious that all of the force would be experienced by the medial collateral ligament, right? So
Yes, sir.
any force from the lateral side would rupture your medial collateral ligament. Is that clear?
Yes.
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 Okay. And any impact from the medial side would tend to rupture your lateral collateral ligament.
Lateral collateral.
We already know that it's very rare to have impact from the medial aspect of your knee, but it's very common to have like impact from the lateral aspect. So you have to take that into consideration, that the most common rupture among medial and lateral collateral ligament is your medial collateral ligament, right? Is that clear?
Yes.
Yes, it is.
Okay, perfect. Okay, for example, if the medial collateral ligament is ruptured, which kind of position your leg is going to acquire? Yes, valgus or varus?
Valgus.
Valgus, perfect. So it would be valgus. Here you guys can see, it means that the knees are going to be knocked while the foot is going to be abducted, right? And on the other hand, if we have rupture of the lateral collateral ligament, then we are going to have which position? Varus, okay, or ball loss. Perfect. Here you guys can see, this is your valgus due to rupture of your medial collateral ligament. And how do we get rupture of medial collateral ligament? We already discussed, if someone just kicks from this side, right, from the lateral side. So all of the force would be experienced by your medial collateral ligament. And in this way, you are going to have valgus position of your leg, okay? So these are the same pictures. Then we discuss our menisci, right? So we discussed that we have crescent shaped pads in between, like your knee joint, which are basically known as menisci, right? So my question for you guys is that how can someone have meniscal injury or meniscal tear, or yes,
When there's
Rotational injury.
so rotation of the knee when the leg is fixed in a position.
perfect. Whenever we have like a fixed leg, pivoted leg, and someone is moving, like not changing his position, it can damage your menisci, right? And as a result of knee injury, you will be having swelling, instability, and a patient would experience whether he's like his knee is falling off. Simple, right? Okay, that's all. Let's discuss anterior cruciate ligament again. Okay, so let me ask you some questions. For example, okay, first of all, just tell me what's the function of anterior cruciate ligament? Yes.
To inhibit the anterior movement.
Okay. Please raise your hands. Please raise your hands. Okay, Dr. Amna, can you just please tell me what's the function of anterior cruciate ligament? It's a kind of revision, right?
Yes, it's the movement for the tibia anteriorly.
Okay, perfect. Okay, my other question for Dr. Ilma is that we have, a test in order to confirm whether we have anterior cruciate ligament injury. What's the name of that, and how do we perform that?
It is anterior drawer test.
How do we,
Perfect.
yes.
Yes.
How do we perform? The patient lies supine, and then you bring the hip, the knee at 90 degree. Then you press
Okay.
anteriorly over the tibia. If you have exaggerated anterior movement of the tibia, then it is positive. So it means that
Perfect.
anterior cruciate ligament is damaged.
Okay, that's perfect. Can you, Dr. Ilma, can you just please tell us the function of posterior cruciate ligament, as we
Posterior
already discussed?
Yes, posterior cruciate ligament prevents exaggerated posterior movement of the tibia, and you test it
Okay.
with a posterior drawer test.
Posterior drawer test. Perfect. So in the same position, you are going to, drag the knee posteriorly. If you have exaggerated motion of tibia, we'll be saying that the posterior drawer test is positive, right? Perfect. Then we have medial collateral ligament injury. Yes. Again, anyone, Dr. Muskan, can you just please tell us how do we get medial collateral ligament injury?
Yes, doctor. For the medial collateral ligament injury, as we just discussed, when there will be the hit from the lateral part of the knee.
Okay, perfect. Okay, once we have damage of medial collateral ligament, okay, it would be a valgus or varus?
Valgus.
Okay, perfect. It would be valgus movement. Can you just please tell me about the the lateral collateral? How can we have lateral collateral ligament rupture or damage?
When there is injury from the medial side.
Perfect. Is it a common or rare scenario?
Rare. It is a rare.
Rare scenario. Perfect. Okay, we already discussed we also have meniscal tear, right? So for
Yes.
example, okay, first of all, how can one have meniscal tear? It's all revision, right? Focus on that, please. Can you just tell me how do one get meniscal tear?
Yes, meniscus tear, like when there is flexion or like the extension of the knee, and like when a person he tries to rotate his
Okay, perfect. If we have an individual, he's like standing
Yes.
firmly, and suddenly he changes the direction of his knee. You are kind of rotating it, right? So
Yes.
it can just give you meniscal tear. Okay, Dr. Daniela, can you just please tell me the test in order to look for the tear of menisci? You already discussed that. Let me just give you a hint. McMurray test.
It's called the McMurray test. Yes.
Okay, how do we do that?
So you lie supine position, and when if there's a pop or pain sound with internal rotation, it means there's a problem in the lateral meniscus. But if there's a pain or pop sound with external rotation, is the medial meniscus.
Perfect. So we have a mnemonic line. If we have pain or pop bilaterally internally rotating it, and if we have pain or pop, it would just suggest that we have rupture of our lateral meniscus. Vice versa. Okay, perfect. Okay. Then we discuss another. Okay, just give me a second. We discussed a term that was bursitis, if you guys remember. So can you just tell me what is bursitis?
Bursitis is the inflammation of
the bursa.
Is a
perfect. It's inflammation of your bursa. Can you just please tell me what is bursa?
Bursa is a shock absorber. It is like a sac-like structure which has a fluid, and it is lined by the synovial membrane.
Perfect. So we have a sac-like structure, and basically it's lined by synovial sac, and it's a kind of shock absorber. It's present between the tendons, between the muscles, in order to reduce friction as well, right? So we have a condition which is known as housemaid's knee. We already discussed that. Let me give you a hint. Pre-patellar bursitis. You have a UWorld MCQ on that as well. Can anyone just tell me what is pre-patellar bursitis? Please raise your hands. We already discussed it. Yes, Dr. Mariam.
Yes, sir, in the pre-patellar bursitis, there is the inflammation of the tendon of the quadriceps that passes through the patella, and they get insertion over the tibial tuberosity. At the insertion site, it gets ruptured, so it leads to the bursitis.
Okay, perfect. Okay, that's right. Dr. Kinana, can you just tell me that why do we call it housemaid's knee?
Yeah, because this happened mostly in people who like it's like a repeated injury, like from the overuse, the repeated kneeling.
Perfect.
So
repeated kneeling. Perfect. So we already
perfect. The people who are always on their knees, like the painters and the plumbers and
like gardeners too. Yeah.
Okay, perfect. So we have pre-patellar bursa. What is pre-patellar? It's like, a kind of in front of patellar bone, right? So if repeated kneeling can cause inflammation there, inflammation can lead to infection, right? You can also have gout. Gout also leads to infection, right? And this condition is known as housemaid's knee. Why? Because it's due to repeatedly kneeling. If you're repeatedly kneeling, it would just cause problems, right? Then we discuss another condition, Baker's cyst. Yes. Okay, first of all, you guys already did the lower limb, you are aware of the nerve. So which nerve is going to be, affected with a Baker's cyst if someone is having Baker's cyst? Tibial. Perfect. That's tibial. And it's a branch of sciatic nerve, right? Perfect. You already know that. Okay. So can anyone just tell me something about Baker's cyst? What is Baker's cyst? Okay,
Like
Dr. Rebecca, please.
It's a fluid filled growth behind the knee.
Hello?
Is Dr. Baker's cyst?
Okay, can you just please repeat it? I wasn't able to hear.
Okay, it's like a fluid filled growth behind the knee.
Perfect. In the popliteal fossa, I can say that?
Yes.
Perfect. And it can cause a lot of problem. It can mimic DVT. We already discussed that. It's common in individuals who are having rheumatoid arthritis, right? We already discussed that. Perfect. And it can damage, it can impact your tibial nerve. We already discussed that, right? So this is your Baker's cyst. On imaging, you guys can clearly see it's present in the popliteal fossa. You guys are already aware with, the nerve supply. So I think you know that tibial nerve is going to be affected more. Okay, we have a condition that is known as Osgood-Schlatter disease. Can anyone just tell me about that? We already discussed in detail. You have a UWorld MCQ on that as well.
It's like the pain in the crossbones pain.
Okay, please raise your hands before participating, please. Okay, Dr. Ramesh, can you just please tell us?
Yeah, okay. So it is due to the overuse of the quadricep muscles because the tuberosity develops as a secondary ossification center. So if there is overuse of the tendon, then there can be separation between the or the detachment of the tuberosity.
Perfect. It can be, shattered into pieces simply, right? If you overusing it due to insertion of the quadricep muscle tendon, it comes over the patella, right? So that is basically known as Osgood-Schlatter disease, or simply you can think of the tibial tuberosity is going to shatter, right? That's why it's known as Osgood-Schlatter. Okay, it's commonly seen in children due to overuse. Can anyone just tell me about patellar fracture? What is patellar bone? What's the function of that? We discussed already, right? Yes, please.
Yeah.
Hello?
To protect the knee from anterior force,
against gravity.
anterior trauma.
Okay, Dr. Muskan, can you just please tell us about the patellar fracture? For example, if someone is having patellar fracture, so what would be the presenting features? What do you think?
First, a person, he cannot walk or stand because there will be the swelling and pain in his knee. And in the patellar fracture, there is no redistribution of the force, basically.
Perfect. We already discussed that this small bone is very important because all of the tendons are going to pass over this small bone and insert it on the tibial tuberosity. It means all of the forces is going to, funnel through this small bone and get redistributed in your lower leg. So it's of much significance. This small bone. You don't have to underestimate it, right? So if now we have fracture, you cannot redistribute your forces. So it's obvious that for standing against the gravity, need extensors, right? So if the extensors cannot, work, so a patient would complain of that he cannot stand against the gravity because he cannot redistribute his force to the lower legs, right? How do we diagnose that? Just do the X-ray and clearly you are going to see, fractured. Here you guys can see fractured patella, right? Is that clear?
Yes.
Yes.
Perfect. So with that, we have ended our knee joint. So let's discuss our shoulder joint, right? So can anyone just tell me about shoulder joint? Okay, can you just tell me the components, right? Like we have glenohumeral joint, which bones just make your shoulder. Anyone please raise your hands? Okay. Dr. Mariam, please.
Yes, sir. The shoulder joint is formed by the head of humerus. It's a
Perfect.
glenohumeral joint.
Okay, so we have
Head
a
of
glenoid fossa. The head of
yes,
okay, the humerus is like inserted in the glenoid fossa, so that's basically known as glenohumeral joint, right? We have
yes,
three bones there. We have our scapula, this is basically present within your the glenoid cavity or fossa is present within the scapula. We have clavicles and we have humerus, three
and
bones, right? So here you
yes,
guys can clearly see this is your shoulder joint. So we have our clavicle, we have our scapula, and thirdly we have our
head of
it's an
humerus.
example of ball and socket joint, right? So
Yes,
we expect a lot of range of movements here, like flexion, extension, abduction, adduction, even rotation, because it's a ball and socket. So you guys can see here you have flexion, okay, and you have extension. Can you guys just tell me, for example, during abduction, I want that glenohumeral joint to be stabilized. Can you just tell me the group of muscles which stabilizes your glenohumeral joint or the shoulder joint?
We have four.
Brachial muscle.
Perfect. We have
Supraspinatus and
perfect. Rotator cuff muscles. And what's the mnemonic for that? Sits, right?
Yes.
Okay.
Yes.
So we have four muscles. We have supra, spinatus. Okay. Dr. Muskan, help me with the names. You have?
Infraspinatus,
Okay, perfect.
teres minor,
Okay.
subscapular.
Okay, subscapular. Okay. So can you just tell me a condition which is okay? So for example, can you just tell me the function of supraspinatus? Okay,
Yes,
why do we call it supraspinatus, first of all?
15
Because it is
degree
present above the spine.
Okay, it's present above the spine. This is the spine.
No, scapular spine.
Spine
Okay,
Spine of the
perfect.
scapula.
The spine of your scapula, right? Not your own spine, right? So spine, we have spine of scapula, and above that we have supraspinatus. What's the function of that? It's going to come. It's going to abduction. Okay,
Yes.
to which degree abduction?
0 to 15.
0 to 15.
Perfect. 0 to 15. If I want abduction above 15, which muscles is going to help me with that?
Deltoid.
After 15?
Yeah. Deltoid.
Before
Perfect. If I need further abduction, which muscles then?
trapezius. Trapezius and
Trapezius. And serratus interior, right? Okay.
Yeah.
Okay, perfect. So then we have, supraspinatus. Can you just tell me that among these rotator cuff muscles, which muscles is going to be affected, for example, injury, impingement, and why is that so?
Supraspinatus. Because of the
Perfect. Supraspinatus, the reason for that is that you guys can see this is your supraspinatus. The tendon is going to come here, and if you are just abducting, so it have a less space, right? So repeated, abduction can sometimes impinge this tendon between acromion process of scapula, the acromion process, right, and the head of your humerus, right? Okay. For example, if you are just suspecting someone with having problems or impingement of supraspinatus muscles, which test do we perform for him? Yes, I think he's going to drink some cane, right?
Empty
can and full can test.
empty and full can test.
Perfect. We have empty and full can test. For example, at 90 degree, if he just if he just emptied the can, he'll be experiencing pain. Or if you have 90 degree abducted arm, you just push it. And again, if you experience pain, it would just indicate problems with supraspinatus muscle. Is that clear? Impingement. Okay. Can anyone just tell me what's the next muscle, infraspinatus? Where is it present?
Below the
spine of scapula.
Spine of scapula. Perfect. And what's the function of this muscle?
External
rotation.
Perfect. External rotation and abduction a little bit, right? Can you just tell me the innervation?
Suprascapular.
Suprascapular nerve.
Perfect. Suprascapular nerve, right? Okay. So do we have any isolated test in order to look for the activity if it's compromised? Okay, raise your hands. Dr. Amis, please.
No, we don't have any specific test for isolated.
Perfect. We do not have any. Okay. Perfect. Okay, that's perfect. So, Dr. Ilma, can you just please tell us about teres minor? What's the function of teres minor muscle?
Teres minor, it does external rotation and also adduction.
External rotation and adduction. Perfect. Can you just tell me the nervous supply or innervation? Which nerve basically?
Axillary nerve.
Axillary nerve. Perfect. Okay. Regarding axillary nerve, we also discussed affect. In which kind of shoulder dislocation do we have damage or compromise of axillary nerve? One of your UL MCQ, anterior dislocation or posterior dislocation?
Anterior.
Okay, anterior dislocation. Perfect. Right? Okay. Then we discuss our last muscle, that is subscapularis. Can you guys just tell me the function of subscapularis?
Internal rotation and adduction.
Perfect. Internal rotation and adduction. Okay. What's the innervation?
Upper and lower subscapular nerve.
Okay, perfect. Subscapular nerves, right? Then we have our brachial plexus, right? We discussed what are your brachial plexus. We already know that brachial plexus are a group of turf of nerves which basically supply your upper limbs, both your motor activities and your sensory nervations. Basically, these nerves are important for that, right? For bringing sensations or innervating different muscles to undergo the motor activity. You already know that. We'll be discussing in details. Don't worry about it, right? Okay, let's discuss our next muscle. That was our deltoid muscle, right? Deltoid. Can you guys just tell me the function of deltoid? You already know that. Yes.
Abduction.
Abduction.
Okay, it's abduction above 15 degree, right? You already know that. So above 15 degree abduction is like going to be, occurring due to your deltoid muscle. And we know the innervation as well, axillary nerve, right?
Yes.
Okay, that's perfect, right? So shoulder dislocation, we already discussed that you can have for example, if someone is having anterior dislocation of shoulder, it's most likely to rupture or damage your axillary nerve. You have a UL MCQ on that as well, right? Then we were discussing our humerus, right? So for the humerus, we already know that we have our proximal humerus. What's the blood supply? Okay, so can you guys just tell me the blood supply for the head of humerus? Anyone? Hello? Hello?
Circumflex.
Okay, we have axillary artery and we have circumflex, right? So axillary artery is basically going to supply, right? So as you guys know, we discussed avascular necrosis, but in which bone? Not humerus. That was your femur, right?
Yes.
And you had your which artery was supplying the head of your femur?
Posterior.
Femoral artery, right?
Complex
That was
femoral
femoral artery. Okay. So here again, axillary artery is going to supply the head of humerus, and again they have circumflex arteries, right? So we can also see avascular necrosis here if the vascular or the blood supply is compromised. Is that clear?
Yes.
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 Okay, perfect. Okay, so this was all about the discussion which we discussed last day. Okay, so let's discuss our brachial plexus now, right? Okay, just give me a sec. Yes, please, just give me a second. Let me just. Yes, please. Any questions?
I was thinking, is the arterial supply of the upper limb is important?
Hello?
Because I was asking if the arterial supply or the blood supply of the upper limb is important.
Okay, it's not that important, but the avascular necrosis, that's important. You don't have to memorize the arterial supply. That isn't important. The nervous supply is most important, right?
Okay.
Okay, just give me 1 minute. Let me just open the slides for brachial plexus. Hello, can you guys hear me?
Yes.
Yes, sir.
Okay, let me just share my screen. Okay. So we were discussing about brachial plexus. We discussed that basically we have a group of nerves which supplies your upper limb, right? We discussed that here you guys can see we have roots, we have trunks, we have division cords, right? And they ultimately give rise to a group of nerves. For example, we'll be discussing in detail axillary nerve, what's the function of that. We'll be discussing median nerve. We already have discussed that, right? It's a kind of revision, by the way. Okay, we have ulnar nerve, we have musculocutaneous nerve, and we discussed we also have trunks, right? So trunks can be divided as upper trunks and lower trunks, right? Like in certain kind of condition, you can have rupture of these trunks, and then we'll be having problem with certain nerves because they give rise to nerves as well, right? We'll be discussing that. Okay, so the first nerve which we are going to discuss is axillary nerve, right? We already know that. Can anyone just tell me which muscles do axillary nerve innervates?
Deltoid, teres minor.
Deltoid muscle.
Perfect. It innervates your deltoid muscle. And what else?
Teres minor.
Teres
Teres
minor.
minor. We discussed that. Okay, perfect. So we discussed that anterior dislocation can damage your axillary nerve. We already know that, right? So if the axillary nerve is damaged, so can I have abduction above 15 degree to 90 degree?
No.
No.
Perfect. Can I have sensations over the deltoid? Can I feel that?
No.
Perfect. Then you have your radial nerve. If you guys remember here, you guys can see you have your radial nerve. What's the function of radial nerve? We already discussed. It's going to supply the posterior compartment. In the upper posterior compartment, it's going to supply your tricep muscle. In the lower forearm, it's going to supply your extensor muscles. You guys are already aware of that. And it also brings sensory sensations from the back of your forearm as well, right? Okay. So for example, if someone is having damage of the radial nerve, we'll be discussing the radial groove, proximal and distal, everything, right? So you'll be having a specific kind of drop. Do you guys remember?
Wrist
drop.
Wrist drop.
Perfect. Wrist drop. Why? If
Because
the
the
nervous
tricep.
supply, yes, so the opposite
flexor
group
will
of muscles. Perfect. Flexors would dominate. If the flexor dominate, you'll be seeing wrist drop. Is that clear? Okay, how can radial nerve get damaged, right? So we can have damage at two locations, right? Here in the axilla or in the radial groove. You guys already aware of a groove on your on the bone, on the humerus. You have a groove in which your radial nerve is going to run, right? So if we have damage of the radial nerve here, so it means the tricep is also going to be not functioning, and the forearm muscles, the posterior or extensor forearm muscles, also won't be functioning well, right? So it would lead to wrist drop as well as problems with the tricep muscles, right?
Right, sir.
Correct.
Okay. For example, if you have damage of the radial nerve here in the radial groove, then the tricep is going to be spared, right? No problems
Yes.
of your tricep muscle. That's obvious. That's something which makes sense. How can one have radial nerve injury? That's also known as Saturday night palsy. If someone is drunk and he's sleeping with an outstretched arm on the chair, it can also compress this nerve, right? So here you guys can see, okay, we discussed the wrist drop. We have your radial sulcus or radial groove. We discussed the proximal and the lateral one, okay? So that was all about your radial nerve, right? Tricep weakness of your finger extensor, and loss of sensation at the hand or forearm, right? Okay. So let's discuss our musculocutaneous nerve. Can anyone just tell me the function of musculocutaneous nerve?
Can I say?
Yes.
Yes, please. Yes, please. Dr. Satarov, you can definitely say.
Muscular cutaneous nerve innervates, brachials, biceps brachii, and I think
Coracobrachialis. Yes, that's also the one. But most important, you will just consider bicep right here for your step one. So, and it also have cutaneous component which is going to supply the lateral forearm, right?
Yeah, right.
Yes.
Perfect. So it's going to innervate your lateral forearm as well. And these nerve lesion, if someone is having the lesion, he cannot flex his arm. That's obvious, right? Now
Yeah.
we'll be discussing the trunk injuries, right? We are already done with the nerves. We'll be discussing the median and ulnar nerve. You guys already know that in detail. We did it a lot of times, right? But let's discuss some trunk injuries. We have upper trunk and we have lower trunks. We discuss how can one have upper trunk injury. For example, if we have a baby and he have shoulder dystocia, increased angle between the shoulder and neck, we already did that. If the shoulder is stuck in symphysis pubis and someone is pulling the baby, right, increasing the angle, it can rupture your upper trunk. You already did that, right? And if the upper trunk is injured, 3 nerves are going to be compromised: your axillary, your musculocutaneous, and
Suprascapular.
suprascapular, right?
Scapular.
So, perfect. So the arm would be adducted, it would be extended and externally rotated, and it would just give us a sign which is known as waiter tip sign, right? You
Yes.
can just assume
Yes.
as a waiter, just like tagging some tip, right? That's all. Okay. Then we discuss our lower plexus injury, right? Also known as Erb's palsy, right? Lower plexus or lower trunk, sorry. How can it get injured? For example, if a child is climbing a tree and suddenly he's falling off and he just had a branch of tree, right? So it would increase the angle between his shoulder, right? And in this way he can have rupture or damage of his lower trunk. Once that's damaged, what happened? We are going to see 2 nerves being compromised: your median and ulnar nerve, right? So let's
Yes.
discuss
Yes.
median and ulnar nerve. We already know that. For example, if this is your hand, we already know that okay, sorry for drawing such a bad hand. Okay, 1 2 3 4 5. Let me just count the fingers as well. Okay, so there are 5. Thanks, Lord. Okay, so we have our median and ulnar nerve, right? So this 1.5 sensations on your palmar side by your ulnar nerve. Ulnar nerve also supplies your hypothenar muscles. Perfect. And all of the introitials, right?
Yes.
Yes.
Perfect. And what about the lateral 2 lumbricals?
Yes, also
It's
it
by the
supplies.
Okay,
median nerve.
perfect. Perfect. And what about the median nerve? It would just supply the thenar muscles, the like 1, 2, 3.5 sensory innervation. It would innervate the medial. Okay, it would they're basically lateral 2, right? They're medial lumbricals. Medial lumbricals and lateral 2 lumbricals are supplied by your median nerve. We also discussed that these are the innervations. So for example, if both of your median and ulnar nerve is gone, so the function of the lumbricals are gone. The function of lumbrical is to make L. And if the function of lumbricals are gone, can I say that now we'll be having a claw hand? You already know
Yes.
that?
Yes.
Perfect. The claw hand. Why? Because you cannot undergo flexion
Flex.
at
Flexion.
metacarpophalangeal.
Yes.
And no, okay, the function is going to be opposite, and opposite function is going to lead to claw hand. We'll be discussing that in the hand module, which is upcoming. Don't worry about that, right? Okay, so this was all. Okay, we discussed about thoracic outlet syndrome. What is thoracic outlet syndrome? We already know that we have a thoracic outlet. What is thoracic outlet? It's above your clavicle and behind your first rib, right? Okay, above your first rib and behind the clavicle, sorry, right? So we have thoracic outlet. So we have a group of, like plexus coming out and a group of, like blood vessels, both arteries and veins coming out between muscles, right? Anterior and middle scalene, right? Between
Yes.
anterior scalene and middle. Okay, you will MCQ on that, right? They just ask you that. Yes, so you have your anterior and posterior scalene. These nerves are going to come out like that, and also the the great veins and arteries, right? So sometimes we can have an extra rib that is known as cervical rib, right? So the hyperextension or flexion can rupture these lower plexus as well, right? Lower plexus or lower trunk. Can I say that?
Yes.
If the
Yes.
lower trunk is ruptured or injured, so again, can I say that we'll be having a claw hand? Can I say that?
Yes, sir.
Yes.
Okay, that's perfect. And the last which we discuss is long thoracic nerve, which is coming out of the roots, right? You already know that, roots. And what's the function of long thoracic nerve? It would innervate the serratus anterior muscle, right?
Yeah.
Yes.
And what's
Yes.
the
Yes.
function of serratus anterior? It keeps scapula against your rib cage. So you have a UWorld MCQ. We have an individual. We tell him to push the wall, push the wall against an outstretched hand, and suddenly the scapula keep on winging, and it basically suggests damage or injury of your long thoracic nerve. Is that clear?
Yes.
Okay, that's perfect. So let's.
Wing
Okay, so
scapula.
yes, perfect. So just give me a second. We'll be discussing our response. Let me just open the slides. Give me 1 minute, right? Hello.
Yes, sir.
Yes, doc.
Okay. So just give me a second. Let me just share my screen. Okay. So let's discuss our. Okay. So we discuss. Okay. I think we discussed these slides. Okay. Just give me a second. I think I've just opened some wrong side. Can you guys just see my screen? Hello? Hello?
Yes.
Yes, sir.
Okay. Okay, perfect. Can anyone just tell me different, we have wrist bones, right? Can anyone just tell me the number of wrist bones? Hello?
8.
Eight.
Eight in
Eight.
number.
Eight, perfect. Can anyone just tell me the name of the wrist bone? What's A, what's B, what's C, D, E, F,
A,
G?
A scaphoid, B lunate,
Okay.
C
B is your lunate, right?
yes, C looks like
What about
pisiform or triquetrum.
Triquetrum.
Okay, it's triquetrum, not fusiform, right?
Okay,
Yeah.
triquetrum.
Okay, what about pisiform?
Pisiform A B C D.
D.
H for
Okay,
hamate,
perfect. Okay, H for hamate,
G for capitate,
G for capitate, perfect.
F for trapezoid, and E for trapezium.
The other way
Okay.
around.
Okay, perfect, right? So, okay, we discussed like an important bone. You have a UWorld MCQ on that as well. You have scaphoid bone, right? So we discussed scaphoid bone, like it's most, like it's most commonly fractured bone, and how to, look for the location. It's basically present at the base of your anatomical snap box, right? And the injury which can damage it is swoosh injury. What do we mean by swoosh injury? Fall on an outstretched hand, right? And it can also undergo avascular necrosis as well, right? Is that clear?
Yes.
Yes, sir.
Okay. Okay, so we discussed our lunate bone as well. Like here, you guys can see this is your scaphoid bone. It can be damage or fracture at its base. So you have an anatomical snub box at the base. You can see this scaphoid bone, right? So then we have our next bone, lunate bone. Can anyone just tell me something about lunate bone? How can it get damaged?
It can get damaged by force injury.
Okay, perfect. Again, it can be fracture in a fush injury. Okay, anything else?
It can compress the median nerve if it is dislocated.
Perfect. It can if it's anteriorly dislocated, it can compress upon the median nerve. Carpal tunnel. We have a carpal tunnel, right? And once the median nerve is compromised, so can you just tell me what would happen as a result of that? Just a little bit. We are going to discuss that in detail. But
Loss of the
Patient.
pinna eminence, and loss of the
perfect.
sensation, loss of the function of the lateral two lumbricals, and also the loss of sensation of the lateral 3.5 fingers.
Perfect. So we already know that median nerve supplies your thenar muscles. We already know that it also supplies the lateral 3.5 fingers, the sensation of that. We already know that it would just supply the lateral two lumbrical as well. So we are going to have problems based on that. We'll be discussing that in detail. So we have a carpal tunnel syndrome. Okay, so one of the students in Dr. Maheen's session was asking that how can hypothyroidism lead to carpal tunnel syndrome? Is it right? Who was just asking this question? Hello? If you guys remember, someone asked this question, right?
Yes,
Yes, sir. Someone
Yes,
asked.
yes.
Okay.
Yeah.
So we are already done with the endocrinology, right? So we discussed that in hypothyroidism we are going to have myxedema, right? Glycose, aminoglycans accumulation everywhere, right?
Yes.
Yes, yes,
Like
doc.
they have a dove-like consistency, non-pitting edema, right?
Yes.
Pitting or non-pitting?
Non-beating.
No.
Okay. So what happened that these glycose aminoglycans can accumulate in the carpal tunnel as well. If they keeps on accumulating in the carpal tunnel, what happens? The median nerve again is going to be compromised. Is that clear now?
Yes.
Yes.
Okay, perfect. Okay, so we have carpal tunnel syndrome. We already discussed a lot of causes for that. Okay, one of an important point which I just keep on telling you guys in the last lecture. What is beta 2 globulin and how can it lead to carpal tunnel syndrome? Yes.
During
Please
dialysis.
raise your hands before answering. Dr. Abdurrauf, please, you can just answer.
Sir, it can occur because of dialysis, because since the dialysis cannot filter out the beta 2 microglobulin, which is a MSC1 particle. So it can get deposited in the flexor retinaculum space and cause the carpal tunnel syndrome.
Okay, perfect. That's perfect. Like it's like during dialysis, you cannot filter out beta 2 globulin, so it can keep on accumulating and it can cause in this way. Okay, acromegaly can also cause carpal tunnel syndrome, right?
Yes, sir.
Yes.
Okay, that's perfect, right? So with this, okay, so we have a tunnel which is known as Guyon. Okay, Guyon's tunnels. Can anyone just tell me about Guyon's tunnels or canal? Which nerve is going to pass through that? That's Dr. Shafiq.
Ulnar nerve.
Perfect. Perfect. And which kind of individual we are going to see like this nerve being compromised? Bicyclists, right?
Yes.
Because the repeated pressure from the handlebars can compromise this tunnel and again this nerve as well. Is that clear?
Yes.
Hello?
Yes.
Okay. Okay, perfect. So here you guys can see, okay, so now let's discuss our hand. And we already have know a lot about hands, its innervation. So I want you guys to answer me that, right? It would be a kind of discussion session because as I already discussed it recently. Okay, so can anyone just tell me about the nervous supply of your, okay, can anyone just tell me about what are extrinsic muscle and intrinsic muscle of hand? Please raise your hands. Miss.
So the intrinsic muscles are those muscles which originate in the palm and also get inserted in the palm. But extrinsic
Okay.
muscles are those muscles which insert in the palm, but they originate outside of the palm, that is in the forearm.
Okay, perfect. So those muscles which originate in the hand and like in the palmar area, as Dr. Amis told us. So we have thenar muscles and hypothenar muscles. Can Dr. Amis, can you just tell me the innervations of your thenar muscles? Which nerve? Thenar muscles.
Median nerve.
Perfect. And what about hypothenar muscles?
Ulnar nerve.
Can you just name me some thenar muscles?
It's the pollicis.
Hello.
Yeah, thinner muscles are like abductor pollicis brevis and
Okay.
opponent's pollicis and
Perfect.
flexor pollicis.
Flexor pollicis brevis. As we know that the term pollicis refer to your thumb and the term brevis refers to small muscles, right? So abductor pollicis brevis means it would abduct your thumb and it's a small muscle because the word brevis means like a kind of small muscle, right? Longest for long muscles. That's a simple terminology, right? And we discussed that thenar muscles are supplied by median nerve. What else median nerve supply? In terms of sensory innervation, again, it's a revision.
Lateral 3.5 fingers.
3.5.
Perfect. Lateral 3.5 fingers, right? Okay,
Yeah.
what about lumbricals?
Lateral to
The
lumbricals.
lateral to
lateral
umbilicus, yeah.
Perfect. Perfect. So, okay, we have ulnar nerve. Can anyone just tell me the muscles which ulnar nerve supply? Again, it's a revision, right?
Yeah.
It's
Hypothenar.
Medial
Perfect.
Hypothenar.
Perfect. Hypothenar muscles. What about the sensory innervation?
Medial 1.5.
Perfect. Perfect. What about introitial muscles? What's the function of introitial muscle? Why do we call it introitious muscles?
Between the bones.
Between the bones. Perfect. And what's the function? Abduction and adduction, right?
Yes.
Perfect. Okay, what's the function of lumbricals, by the way?
Making an L of the finger.
Yeah.
So that means
Perfect. Making an L. So how do we make L? Can I say
Flex.
that lumbricals would
Flexion.
flex? Okay. Can I say that lumbricals would, cause flexion of your metacarpophalangeal joint and extension of interphalangeal joints, right? Like here you guys can see. It's flexion of your metacarpophalangeal joint and extension. So we already discussed if the lower trunk is injury, both the innervation of ulnar and median nerve is gone. when the innervation is gone, the innervation to lumbricals is also gone. So now you cannot flex, right? So what happens? The
Yes.
metacarpophalangeal are going to be extended, and you cannot extend. So it means the interphalangeal ligaments are going to be flexed. It would just give you a claw hand. Simple.
Yes.
Is that
Sir.
clear? Okay.
Yeah.
Okay, we also discussed, we discussed some extrinsic muscles of hand as well. Like the one of the muscle, if you guys remember, that was flexor digitorum profundus, right? It's
Yeah.
an extensor, so it's going to make a fist, right? If it's an extrinsic muscle, it means it would, arise from the forearm and innervate in the palm, as Dr. Hamid already told us. And again, the lateral two are supplied by median and the medial two by the ulnar, right? So they have same innervation as that of your lumbricals, because lumbricals arises from the tendons of these muscles. Is that clear?
Yeah.
Okay, perfect.
Yes.
We discussed about wrist deviation. We discussed ulnar deviation and radial deviation. So how can one have ulnar deviation of his wrist? Can anyone just help me, please?
Yeah, when
Median
the,
nerve injury.
Okay, perfect. Okay, so we discussed median nerve lesion. Okay, for example, if you have an individual who have median nerve lesion, right, and I'm just telling him to make fist, so he'll be just like like that. He'll be having a Pope's
Yeah.
blessing, right, or hand of
Yeah.
benediction. Why? Because if I'm just telling him to close his or make a fist, his lumbricals aren't functioning because the median nerve is gone. So what happens? You'll be having extension here and flexion here, giving you hand of benediction, right? But if the hand is at rest, it would be an apse hand, right? Because you are not seeing a thenar eminence, and here you guys can see the lumbricals are gone. So once the hand is like kept like normal on the surface of the table, let's suppose, so it would be resembling an apse hand. Is that clear? Okay,
Yes.
another thing which we discussed, the median nerves come here like that. So if you have supracondylar fracture, one of your UWorld MCQ, supracondylar fracture damages which nerve? Median nerve, right?
Median nerve, yes.
And we'll be seeing ulnar deviation, right?
Yeah.
Yes.
Okay, perfect. So for the ulnar nerve, we already discussed, for example, if the function of ulnar nerve is gone, we are just telling this individual to, okay, the lumbricals are gone. If the lumbricals are gone, what happened? If you are just telling this individual to keep his hand on rest, you'll be having like a hand like that, because as the lumbricals aren't functioning, so here you guys can see you'll be seeing extension at a metacarpophalangeal joint and flexion. Is that clear?
Yes.
Okay, perfect. So this was all about your hand. Let's discuss our next topic, that is lumbosacral plexus. But before that, let's have 5 minutes of that, right?
Yes, sir. Thanks.
Okay. Thank you so much. See you after 5 minutes.
Thank you.
Hello, can you guys hear me? Hello? Hello?
Yes, sir.
Okay, perfect.
Yes, sir.
Let's continue our discussion and let's discuss lumbar plexus, right? So can anyone just tell me what are lumbar plexus? Hello?
Nerves from T12 to L4.
Perfect. So we have a collection or a network of nerves from T12 to L4. Again, what's the function of them? They're going to supply your lower limb, right? The muscles and bring sensory innervations as well. We'll be discussing that, right? And again, we have sacral plexus. Okay, these are your lumbar plexus and your sacral plexus, right? So sacral plexus comes from the sacrum, and together we
Oh,
are
you
going to call
can't
it.
see your screen. You're not sharing.
Okay, just give me a second. Let me just share my screen. Can you guys see my screen now?
Yes.
Okay, perfect, right? So we have sacral plexus as well, which come out from the sacral region of the spine, and collectively they are going to contribute in a structure which we are going to call it as lumbosacral plexus, right? So lumbosacral plexus are going to innervate a lot of muscles in your lower limb. So the first nerve which we are going to discuss is iliohypogastric, right? We already discussed iliohypogastric nerve, so I'm expecting Dr. Rauf to please tell me something about iliohypogastric nerve. What muscles do it innervate, and what's the sensory information which this nerve is just carrying on?
So, sir, basically, this has both a sensory and a motor component.
Perfect.
And it is basically supplying the suprapubic region and the transverse abdominis and internal oblique.
Okay.
And like you said, it can get injured in surgeries and laparoscopic surgeries like hernia repair because the sutures can entrap the nerves.
Okay, that's perfect. So it's going to supply different muscles. Which muscles? Internal oblique and transversus abdominis, which we discussed, right? Then the sensory innervation, the suprapubic area, right? So you have your transversus abdominis, internal oblique, which is being innervated by this nerve. We have sensation from the suprapubic region. For example, if we have a laparoscopic surgery, if we have a transverse skirt, sometimes the suture can entrap the nerve, which can cause problems, right? Our next nerve, which we are going to discuss, is genitofemoral nerve, right? So we discuss genitofemoral. For the genital part, we have motor and sensory innervations, both, right? So for the genital part, remember, it's going to supply cremasteric muscle. What's cremasteric muscles? It's a muscle which surround, cover your testicles and spermatic cord. We have a reflex, which is cremasteric reflex. For example, tapping the internal thigh, it would, lift the scrotum on the ipsilateral side, right? That's simply known as cremasteric reflex, which is due to genitofemoral nerve, right? Okay, what's the sensory innervation of genitofemoral nerve or the femoral part? Yes.
Scrotum and labia.
Okay, perfect. So it's going to supply the sensory innervation to scrotum and labia, and again, it's also going to supply sensory
Vagina.
innervation to vagina. Perfect, and upper anterior thigh as well, right?
Yes.
Like upper anterior thigh is also being supplied by. Okay, the sensory innervation is supplied by this. For example, if you have damage of genitofemoral nerve, what would happen? Absent cremasteric reflex. We already know that, right? And decreased sensation on labia and scrotum, as well as decreased sensation in upper thigh. Is that clear?
Yes.
Okay,
Yes.
then we discuss our next nerve, which is lateral femoral cutaneous, right? It's purely sensory nerve, right? And which portion of the thigh is being supplied by this nerve? Yes.
Anterior and lateral.
The inner aspect of the thigh.
Okay, perfect. Lateral aspect of your thigh. Can anyone just tell me in which kind of individual this nerve is compromised or compressed?
In the obesity, pregnancy, tight cloth.
Perfect. Obesity and pregnancy, if they are just, having some tight clothing, it can, compromise this nerve. That's perfect, right? So our next nerve was your obturator, right? And we discussed the term obturator mean to close. To close mean adduction, right? So all of the adductors are supplied by obturator nerve, but you have a little bit sensory innervation at the medial thigh as well, which is being supplied by obturator nerve, right? So if the obturator nerve is compromised, you cannot adduct the thigh. You cannot add the thigh, right? Adduct. Is that clear? And how do we have compromise of this nerve? If you guys remember, the trocar is inserted too deep, right? Here you guys can see the trocar is inserted too deep in a pelvic surgery. It can compromise this obturator. Is that clear?
Yes.
Okay. So the next nerve which we are going to discuss is femoral nerve, right? So femoral nerve is going to supply the anterior thigh muscles and the flexors, hip flexors, right? So we know some of the hip flexors. We have your iliopsoas muscles, which they're going to combine here, like making iliopsoas, which is going to flex your hip. We have our next, that is pectineus muscle, right? The small muscle which also flexes at hip joint, and sartorius muscle, right? Your sartorius muscle. Is that clear?
Yes.
Yes.
Okay, perfect. So in the anterior thigh, we have quadricep muscles. We already know that.
Yes.
And what are your
Yes.
quadricep 4 muscles? Your rectus femoris, vastus lateralis, medialis, and intermedius, right? So let's discuss here. Your anterior thigh basically have your rectus femoris and vastus medialis, vastus lateralis, and beneath your rectus femoris, you have a muscle which is vastus intermedialis. Is that clear?
Yes.
Okay. We also discussed that femoral nerve also have a branch which is known as, we give saphenous nerve, right? So, for example, in a cabbage procedure, if we are just taking saphenous vein, sometimes the surgeon can compromise this nerve as well, and as a result of that, sensory innervation to the medial aspect of leg is lost, right? Is that clear?
Yeah.
Okay. For example, if you want to do surgery in the anterior thigh, if we want to numb the femoral nerve, we have to palpate it laterally to artery, right?
Yes.
Naval.
Yes.
NAVL, nerve, artery, vein, and lymph nodes, right? So lateral to femoral artery, you can find this nerve. If you want to do, let's suppose, anterior compartment surgeries, if you want to numb this nerve, you're going to give anesthetics there. Simple as that, right? We also discussed that femoral nerve is important in your patellar reflex, right? Because patellar reflex is simply a kicking of your leg. Because we already discussed that for quadricep muscles, they're going to insert on the tibial tuberosity. If I'm just pulling off these muscles, leg is going to kick, right? That's simply known as patellar reflex. And patellar reflex basically is, yes, it tests the function of your femoral nerve. Is that clear?
Yes, doc.
Okay, that's perfect, right? So here's your patellar reflex. You guys can see. Okay. So then we were discussing our sciatic nerve, right? And branches of sciatic. So first of all, we were discussing the distal portion of the sciatic nerve, right? Okay, so can anyone just tell me the branches of sciatic nerve? Distally.
Perennial and tibial.
Perfect. Common peroneal and tibial. Common peroneal is also known as common fibula because it wraps around the heart of fibula, right?
Yeah.
Perfect. So can anyone just tell me the branches of common femoral further?
Yes.
Okay, common fibula, sorry. Okay, so it's a superficial and deep fibular nerve, right?
Yes.
Which compartment of muscles are supplied by superficial fibular nerve?
Lateral.
The lateral.
The lateral part of the legs.
Perfect. And what's the function of that lateral compartment of muscles?
Eversion.
Eversion of foot. Yes,
Eversion.
that's perfect. Right. I think you guys have done this module so perfect. You guys are answering me. I'm so proud of you guys. Okay. Then we have deep fibular nerve. Which muscles compartment do deep fibular nerve supply?
Dorsiflexion of the
Anterior.
foot. Plantar
Perfect. Okay, that's perfect. Dorsiflexion of foot, right?
Yes.
Yeah.
Okay,
Yes.
that's perfect. If we have injury to the common peroneal, so we'll be seeing foot drop. Can I say that?
Good drop. Yeah.
Yes.
Yes.
Why? Because the opposite compartment muscle. What are the opposite? The posterior compartment supplied by tibial. It does plantar flexion. It would dominate and it would give you foot drop. Is that clear? You have a
Yes.
world MCQ
Yes.
on that as well, right? Okay. Then we discuss our tibial nerve. Becker cyst can compromise your tibial nerve. We already did that, right? It also has sensory innervation to the heel and sole. We already know that, right? So it's going to supply the posterior compartment of your leg. Here you guys can see. And as a result of that, okay, it would undergo the dorsiflexion. Then our last nerve was your pudendal nerve. We discussed pudendal nerve in our in a lot of modules, if you guys remember, in our renal module. So I want Dr. Amis to tell us something about pudendal nerve.
Okay, so pudendal nerve is the name pudendals mean to be ashamed. So it's supplies the levator sphincter muscles, and it's
It supplies
supplies the
genital area. It supplies perineum. It supplies Yes, external urethral sphincter and external anal sphincter, right? And levator and eye muscles. Okay,
Yes.
so how can multiple surgeries or multiple vaginal delivery affect this nerve?
Yeah, multiple vaginal delivery can damage this nerve, and so for that we do Kegels exercise to strengthen it.
Perfect, perfect. The first line for management is Kegel exercises, right? And that was
Yeah.
also one of your UWorld MCQ, if you guys remember, right? So this was all about your pudendal nerve. So our next topic of discussion would be radiculopathy. We already did radiculopathy in a really detail. So please raise your hands. Okay, Dr. Kenana is going to tell us what is radiculopathy.
Yes, sir. So it's like it's the conditions that affect like the herniated disc, the spinal stenosis that lead to compression of the nerve roots as the spine.
Okay, perfect. So radiculopathy simple is compression of the nerve root at the spine. You have a lot of causes. Herniated disc, as you told us. Spondylolisthesis, right? Slipping of, vertebrae over one another can also do that. And spinal stenosis, right? So we discuss intervertebral disc. There are cushions between the vertebrae. They have to areas. You have nucleus pulposus, which is remnant of your notochord. We have our fibrous annulus, right? And as we know that the posterior longitudinal ligament is the weakest one, so you can easily have herniation of vertebral disc here in the spinal canal, which can compromise the nerve, which can cause radiculopathy, right?
Yes.
Okay, so we discussed that spondylolisthesis can also do that. Like, for example, if this vertebral column slips over one another, again, you can have compromise of this nerve. We also discussed the spinal stenosis can also do that. Like, for example, if we have hypertrophy of ligamentum flavum, right? So it can narrow down the lumen, and as a result of that, it can compromise the spinal nerve, giving you radiculopathy. So how to assess an individual, or how to, say that he has spinal stenosis?
It's just that the pain increase while standing because this will narrow more the lumbar canal and lead to more stenosis and more pain.
And what about if a person is, flexing? He's just bending forward.
Yeah, he's gonna get better.
Relief.
Better, perfect, because you're increasing that lumen kind of, okay, perfect, right? So our next topic, which we are going to discuss is, okay, this was all about like sometimes, these facet joint can undergo, they can rub over one another and you can have reactive bone formation, which can again compromise the lumen and it can cause radiculopathy. Is that clear?
Yes, sir.
Yes.
Okay, perfect. So now we are going to discuss sciatic nerve, that the proximal portion. So your first UWorld MCQ: how can one have damage of this nerve? Anterior dislocation of your joint or posterior dislocation?
Posterior.
Perfect. Okay. So it's going to supply the posterior compartment. To which muscles are present in the posterior compartments? What's the function of those muscles?
Hamstring muscles, and
Perfect.
they extend the knee and flex the knee. They extend the hip and flex the knee.
Perfect. They extend the hip and flex the knee, right? Okay. So we have hamstring muscles that are like semimembranosus, semitendinosus. You don't have to remember that. Okay. So we have a condition that is known as sciatica. What is sciatica? Anyone?
Impingement of sciatic nerve.
Okay, perfect. We already, it's the longest nerve, right? So for example, if sciatica is due to radiculopathy, so which nerve root are you suspecting to be the common one which is involved, right? So sciatic nerve is made up of a lot of spinal root nerves, right?
L5.
So L5, perfect.
L5.
So L5 is the common one, right? What's the next or the second common?
S1.
S1, perfect, right? So if we have problems with let's suppose if we have problems with L5, so what would you expect in this individual? Can he undergo dorsiflexion?
No. He have a weak dorsiflexion and he's
Weak
gonna
dorsiflexion.
have difficulty walking on the.
Perfect. He cannot walk on his heels, right? Because if someone is walking on his heels, you need dorsiflexion for that, right? So simply we can think of if the L5 is affected. So dorsiflexion normally was carried by which nerve? We discussed specifically.
Cranial nerve.
Cranial nerve.
Okay, peroneal nerve, right? So it means that peroneal or common fibular is going to be affected, right? Okay, if we have perfect. So if we have sciatica, and in that we have radiculopathy of S1, then we will be having V plantar flexion. That is like the tibial portion of sciatic nerve is more going to be involved. Is that clear?
Yes.
Yes.
Okay, perfect. And what about the knee? Okay, what about the knee reflex? Will we be seeing knee reflex? The patellar reflex?
Reduce very less.
Yes, it will be reduced. Perfect. And what's the test for that? Can anyone just tell me how would...
Physical sign.
Okay, yes, Lazik sign. If straight leg, if you're just raising the leg, if you are just experiencing like pain, if the pain worsen, it would just like mark, or it would indicate that there is radiculopathy going on. Again, what's the idea? You're narrowing down the lumen, right?
Yes.
Yeah.
Okay, that's perfect. So let's discuss our last topic for the anatomy, that is hip joint, right? So
yes,
can anyone just tell me something about hip joint? How do hip joint? What are the components of hip joint? Simple.
It's
the ball and socket joint.
Ball and socket.
Perfect. If it's ball and socket, so which range of movements are you expecting here?
It's rotation.
Perfect. We are expecting abduction, adduction, flexion, extension, and things, right? Okay. We have we have head of femur attached or inserted in acetabulum of your pelvis, right? So you have your pelvic bone. We have a cavity there, which is known as acetabulum, right?
Yes.
What are your major hip flexors? We already know that. We discussed pectineus, sartorius, and iliopsoas, right?
Yes.
Yes, sir.
Perfect. What are the major extensor? We discussed gluteus maximus, right? Gluteus maximus and hamstrings.
Gluteus
Perfect,
minimum.
right?
Yeah.
Okay, perfect. What are the abductor?
Medius and minimus.
Yes.
Medius and minimus.
Minimus.
What's the
Minimus.
nervous supply of medius and minimus?
Superior gluteal nerve.
Sorry?
Superior gluteal nerve.
Superior gluteal. And what about gluteus maximum? Inferior, right?
Inferior one.
Yes.
Perfect. That's perfect, right? So, can anyone just tell me something about Trendelenburg sign? You have a lot of UWorld MCQs, by the way. How can one have Trendelenburg sign?
Due to injection.
Okay, injection.
Yeah.
Basically,
Medial
okay, what's the
aspect.
safe? Okay, perfect. What's the safe, like quadrant for the for intramuscular injection in hip?
Lateral.
Lateral aspect.
Upper lateral, right? If we have intramuscular injection upper, medial, so which nerve is going to be affected?
Superior gluteal nerve.
Superior
Perfect.
gluteal.
If we have injection in the lower quadrant, what do you suspect? Which nerve is going to be affected?
Sciatic.
Sciatic. Perfect, right? So if the superior gluteal is involved, we won't be having abduction, right? Like the function of your medius and minimus is lost, and as a result of that, what happens? You'll be having a sign which is known as Trendelenburg sign. Can anyone just tell me what is Trendelenburg sign? You have a lot of you practice a lot of UWorld MCQs on that as well. I know that.
The hip drops on the contralateral side to injury.
Perfect. That's perfect, right? So our last topic is avascular necrosis. Again, you have a lot of UWorld MCQ on that. Can anyone just tell me what is avascular necrosis?
It's a compromised supply to the head of the femur.
Okay, can anyone just tell me some of the causes, like the unknown causes, unknown mechanism? Glucocorticoids, perfect.
A means no blood supply. So
Okay. Compromised blood.
Sickle cell disease.
Sickle cell disease, we already know that if the sicklings occur, in the microvasculature, we are going to have sickling, dactylitis, acute dactylitis. Remember, you have a UWorld MCQ on that, hematology section.
Yes.
It can also compromise the blood supply of your femoral head, which can lead to avascular necrosis. Is that clear?
Yes.
Okay, so I congratulate you guys on finishing your anatomy boot camp. So we'll be starting on pathology now. Are you guys enjoying?
Yeah.
Yeah, it was good. Great.
Yes,
Thank
doctor.
you.
Yes.
Okay, thank you. Like it's a kind of
I have just a small questions. I don't know Valgus virus. I don't know what how I could remember them. Can you help in that in the knee?
Okay, we have our valgus movement and varus movement, right? What is valgus movement? Valgus, it's a knee, knock knee with your foot moving with your foot abducting, right? So valgus for knock knee, right? How do we get that? If you have fracture of your medial collateral ligament, right?
Yes.
So simply you
Valgus
can,
means outside, doc. Means
okay, whenever
outside.
you see valgus, so for the G you can simply remember that
Doc,
you
Come again, doc.
doc, doc.
an inverted V, right?
There is. I remember it with a mnemonic. Maybe that is
Yes,
kind
please.
of like inappropriate, but as you know that for obturator you mean to close it. So for valgus, you can think as vulgar. So for vulgar, it's like we can relate that. So you'll not forget.
Yeah, so it's a vulgar kind of position.
Yeah, yeah. I know it's inappropriate, but it makes remembering it is very easy.
Yes, just it's okay. We we can use inappropriate things for appropriate things for medicine, right? That isn't
Yeah.
a risk. You can use that. Okay. Okay. Thank you.
So valgus means
Yeah.
away from each other.
Yes. Away.
Okay. And this,
Stay away from
yeah,
body.
and the medial cruciate ligament injury. Okay. Yes.
Okay. So okay. So let's
Thank
discuss
you,
our
doc. Thank you.
pathology section. Okay. Thank you so much. Okay, you should thank Dr. Amis for that.
Yeah. Sorry. Hmm.
Okay. So let's discuss our pathology section. And the first pathology which we are going to discuss is achondroplasia, right? Achondroplasia. You have a word MCQ on that as well. We discuss what is achondroplasia. A mean without or less activity or deficit. Whenever we use the word A, right? Chondro
Yes.
means your cartilage and plasia mean
Cartilage.
growth. So whenever there is problems with cartilage growth, so what would happen? Now a question should arise that we have two kinds of bone growth, right? So we have endochondral bone growth, endochondral, and we have intramembranous, right? So for the flared bones, we know intramembranous. We have discussed each and everything. It's a boot camp session, right? So I'll be a little bit fast, right? It's only for your revision. So we have our intramembranous for the flared bones in the skull, while endochondral bone for the endochondral ossification for your long bones, right? So what did you expect in an individual having endochondral, achondroplasia?
We will have short limbs and legs, but body is normal.
Perfect.
The long
Okay,
bones short.
Okay, perfect. Let's have discussion over this pathology because we have recently did it. Okay, so I'll be selecting you guys. Okay, Dr. Ilma, can you just please tell me that we have overexpression of a receptor here? Can you just name that receptor?
Fibroblast growth factor receptor 3.
Perfect. FGFR3, right? And it would inhibit the growth, right?
Yes.
Okay, endochondral bone formation, right? That's perfect. Osteogenesis imperfecta, imperfect formation of your bone. Okay, who is going to participate, please? Okay, Dr. Satarov, can you just please tell me that in osteogenesis imperfecta, which collagen is defected? We have mutation in which leads to which defect in which collagen?
Collagen 1.
Okay, perfect. Collagen 1. Okay, collagen 1 helps in formation of cartilage or bone?
Yeah, it's
Bone.
Bone, B-O-N-E, right?
Yes.
Okay, but type 1 collagen, Dr. Satrov, is present somewhere else as well. Can you just please tell us? In the sclera. Sclera, perfect.
Like the sclera in the ear.
Okay, perfect. Okay, in your bones,
Conductive hearing loss.
Okay, conductive hearing loss, perfect, because bones are also present in your malleus incus small bones, right? Sapes. So they also need collagen type 1. So if we have defected or bones in the ear, it can lead to conductive hearing loss, right? Okay.
Yes.
What about why do we have blue sclera, Dr. Satrov?
Sorry?
Okay, in osteogenesis imperfecta, you have a word MCQ, you are going to have blue sclera. Blue sclera, why?
because of absence of collagen 1 formation.
Okay, because of absence of collagen 1, the choroidal plexus or the choroidal veins are going to be exposed. Veins are blue in color, right? So we'll be seeing
Yes.
blue sclera. Is that clear?
Yes, doc.
Perfect. Dr. Azadi, Azade, can you just please turn on your mic?
Yes.
Okay, so let's discuss osteoporosis. Can you just tell us what is osteoporosis?
Also, porosis or petrosis?
Okay, porosis, not petrosis.
Okay. Osteo means bone, and porosis, pore means pore and weak. So
Okay.
when we have the pore in the bones and they're weakened, and the bone mass is reduces, we have osteoporosis. And we have our peak bone mass in 30 years old. And
Perfect.
after that,
How
it
can
would
we
be-
get
yeah.
maximum peak bone mass? What 3 factors are important for that in order to have maximum peak
Yes.
bone mass?
It's first of all exercising, diet, and vitamin D, because the genetic is important because of the vitamin D receptors.
Perfect.
Yeah.
Okay, after 30 years of age, we are going to have decreased peak bone mass by 1%, right? We already discussed each and everything in detail, right? So I was consider it as an Anki session, right? For a space repetition. Okay. So for example, if I don't want to lose my bone after 30 years of my age, again, which 3 factors are going to help me, or which 2 factors specifically? The diet and exercise, right? Again.
Exercise and diet.
Perfect. So Dr. Kinana is going to tell me that in osteoporosis, can you just tell me what would be the lab findings? Would it be normal or abnormal?
Normal.
Normal. Perfect. Whenever you see normal lab values and you have problems with bone, that is fractures, think of osteoporosis. Is that clear?
Yes.
Okay, perfect. So let's discuss our next pathology, that is osteopetrosis, right? Anyone who want to participate, Dr. Victor is going to open his mic and participate. Dr. Victor, can you just please tell me what do the term osteopetrosis mean? Hello? Dr. Daniela? Yes, please.
Oh, it just means thick bones.
Okay, it's like a thick bone, right? Petrosis, like the word term petrosis stands for like,
Compact, yeah. Compact.
Okay, stones or thick. Okay, compact. So, for example, if you have a thick bone, so how do you have that? What's the problem going on in osteopetrosis?
Bone resorption failure.
Yeah, imbalance between the osteoclast and osteoblast, right?
Can I say that the bone resorption is impaired?
Yes.
Yes.
Can I say that you do not have you need acidic environment for the osteoclast to function? But
Yes,
if you
you
do
do.
not have
Yeah.
acidic environment, we will be having impaired osteoclast function. And as a result of that, you will be having thick bone, but that thick bones would be weak, like a chalk. Yeah, you can easily break them off, right? Okay, so for the acidic environment, which enzyme is required?
Alkaline phosphatase.
Carbonic anhydrase. Perfect. So can I say that?
Myeloblast.
Yes, perfect. So can I say that this pathology is going to be due to problems in carbonic anhydrase too?
Yes.
In carbonic
Yes.
perfect.
Carbonic
Okay.
anhydrase.
If we have thickening of bone, how can I have hydrocephalus? Can you just explain?
Because of the foramen magnum thickening.
Perfect. How can one have vision and hearing impairment?
Because of
they're gonna
Nerve impingement.
Perfect.
Skull bone thickness and the
Nerves.
compression of
Okay, please, one by
visual,
one,
yeah.
one by one. Okay, Dr. Abaika, can you just please? Okay,
Is
perfect. Dr. Abaika.
of the cranial nerves.
Okay, Dr. Rebecca, can you just please tell us that why we are going to see anemia, thrombocytopenia, or simply pancytopenia in osteopetrosis?
That will be due to the bone replacement of myophysis process.
Okay, myelophysic process. That is, that this bone will just replace the medulla, right? Where we have hematopoietic stem cell that cannot make different blood cells, right? Dr. Gyanshi, can you just please tell me the treatment of this condition? What do you think? Hello, Dr. Gyanshi?
Can I say?
Yes, please.
Like there is like couple of method of treatments. The first is the medication, just to stimulate the bone resorption, and the second one is like this physical therapy to improve the bone strength and the mobility, and there's also the surgical, and like just to correct the bone deformation, and also there is the bone marrow transplant.
Perfect. Bone marrow transplant, right? Because your osteoclasts are simply your macrophages, right? Okay, so let's discuss our next condition, which is rickets and osteomalacia, right? So Dr. Abdurrauf is going to tell us what is ricket and osteomalacia? What's the main problem going on there?
So, basically, there is the vitamin D deficiency, or
Perfect.
unable to process it. But if it in the children, so we will call as at rickets, and if it in the adults, so we call it as osteomalacia.
That's perfect. Vitamin D deficiency. So we already know that how we get vitamin D. We get vitamin D from sunlight. We get vitamin D from our diet. It's a fat soluble vitamin. So from the sunlight, and first of all, from the sunlight, it's going to be hydroxylated, 25 hydroxylation in liver, then 1 alpha hydroxylation in kidney. So if you have problems of liver and kidney, again, it would lead to vitamin D deficiency. Can I say that?
Yes.
Perfect. Right? Okay. So in the
Yes,
in
and
rickets,
also medicament.
yes, please.
And also medications also can cause to like osteomalacia and the vitamin D deficiency.
Perfect. That's,
for example,
yes, please.
steroids.
Okay, perfect. Okay, so yes, you guys can just keep on adding the points as well, right? If I'm just missing something. So we discuss rickets. It's basically vitamin D deficiency in children. Okay, so what would be the clinical features of a child having rickets? Dr. Dr. Azadi, yes, please, you can just tell us.
Yes, it's the pigeon chest deformity and
Okay.
the frontal bossing. And in the osteochondral junction, we have a rachitic rosary. It's like
Perfect. So why do we have rachitic rosary, or why do we have frontal bossing?
Because the osteoid is being laying constantly and it is not getting mineralized.
Perfect. We have a lot of osteoid deposition, right?
Yes, sir.
Perfect. So let's discuss our next pathology, which is Paget disease of bone. So for that, who want to just participate, please raise your hand. Dr. Elma.
Yes,
Yes.
doctor.
Yeah. Can you just please tell us something about Paget disease of bone?
Okay, so in Paget disease, we have three phases. We have the osteolytic phase, where the osteoclasts play the most important part. Then we have the mixed phase, when we have osteoclast plus osteoblast. And the last one is the osteosclerotic phase, where the osteoblasts play the most important part. In Paget disease,
perfect. So your first phase is... Yes, please. Yes, you can carry on.
In the first phase is osteoclast. In the lab findings, we have all are normal, but all the ALP is high, so alkaline phosphatase is high. About the findings, what you see the bowing of the legs. You see hearing loss because vestibulocochlear nerve is impinged. You have the frontal bossing. That's why these people keep changing their hats, because their head gets bigger. Bowing, arthritis as well. Bowing of the leg. Yes.
Perfect. Okay. So Dr. Muskan, can you just please tell me the clinical features of an individual having Paget disease?
Yes, doctor. So there will be the bone pain. Yes.
Okay.
And hearing loss. And what more? As the doctor
Again, we can have, yes, perfect, impingement of cranial nerves, which can lead to hearing losses. Perfect, right? What do you think would be the treatment if it's the osteoclast causing the problems, in the first place? So what do you think would be the treatment?
Calcitonin.
Oh, yes, eliminate your osteoclast. How? By giving bisphosphonate or calcitonin. An important point that Paget disease can also increase the risk of osteosarcoma and high output cardiac failure. Can anyone just explain it a little bit? Why?
Because for the high output cardiac failure, it will happen because I guess shunts gonna form in the bone. There will be
if you're having a lot of bone formation in the end, it means that there is increased chances of getting AV shunts, because bone is also full of arteries and veins, right? And if we have AV shunts, it can lead to, okay, what would happen to afterload if we have AV shunt? We already did cardiovascular, so let me just ask you guys that question.
Increase
What will
afterload.
be
Increase.
Decrease
will be
afterload.
decrease?
Increase or, okay, Dr. Muskan, increase or decrease?
Decrease.
Doctor, I think just a second. No, I
It
think
would be, it would be decrease, right?
yeah,
Yeah,
decrease.
of course.
Okay.
There.
Okay. And why do we have increased chances or risk of osteosarcoma? The idea is very simple. If you have increased formation of bones, so there is increased chances of mutation as well. Mutation in turn can lead to malignant cancers, right? We already know that. Is that
Yes.
clear?
Excuse me, Dr. Ahmad. I just wanted to confirm, why do we have more arteriovenous shunts?
Okay. So the idea is really clear, right? For example, okay, in the end of Paget disease, we have like osteoblastic activity, right? You're laying down a lot of osteoid, right?
Yes.
Hello?
Yes.
If I'm just making a lot of bone in a rush, so bone need blood supply as well. It have a lot of blood supply. It needs arteries and veins as well. It needs like nutrients, right? So the blood supply is also going to be made in rush. So there is increased chances of getting AV connections, arteries connected to veins, if you are doing everything in rush. Does that make sense?
Yes, it makes sense. Thank you so much.
Yes. Okay. Right. So our next topic is going to be bone tumors, right? So for the bone tumors, I need everyone to participate. Okay. So I'll be calling your names. Okay. So Dr. Abida Azimi, can you just please turn on your mic?
Yes, sir.
Okay. Can you just tell me what is, okay, how do we, okay, we have OMA and we have sarcoma. For the OMA, we are going to say that it's a benign tumor, right? And whenever we see the word sarcoma, it would be malignant tumor, right?
Yes.
Can I say that?
Yes.
Perfect.
Yes.
So we have our first bone tumor, osteoma. Can you just please tell me something about osteoma? What's the best location where you can see osteoma?
Mostly osteoma, they're in facial bones, and also they are like associated with Gardner syndrome, and I think that's it.
Okay.
And
Okay.
it's
It's also associated with Gardner syndrome. So can you just tell me something about Gardner syndrome?
Gardner syndrome. This is that familiar adenomatous polyposis problem. If I'm not wrong, with GI, this is,
Yes, that's perfect.
and they also have associated with some hearthomas. Yeah, osteosarcoma.
Okay.
Yeah.
Okay, perfect. So we are going to see like three things: osteoma, familial adenomatous polyposis, and increased fibroblasts in the retroperitoneum. We'll be discussing that in detail, right?
Yeah.
Our next, okay, so thank you so much, Dr. Abida. Dr. Adonia Fleming, can you just please stand on your mic? Dr. Adonia Fleming, please. Okay, Dr. Amna KB, can you just please turn on your mic? Hello, Dr. Amna. Okay, please. Can you just tell us something about osteoid osteoma?
Osteoma, it's a benign tumor,
Perfect.
and it's of the osteoid.
Okay, so it's basically a benign tumor of osteoblast, right?
Yes.
Okay, perfect. So if it's okay, can you just tell me, we are going to see this tumor in the cortex or medulla?
Medulla.
Hello? It arises in the cortex of long bone. Okay, thank you so much. Thank you so much. Okay. Dr. Anisha, can you just please turn on your mic? Hello? Okay, Dr. Azadi, can you just please turn on your mic?
Yes, sir.
Okay, can you just tell us something about your osteoid osteoma? What is osteoid and what is osteoma? We already discussed that. For example, if you're going to have benign tumor of osteoblast, we are going to have a lot of osteoids surrounded by a rim of reactive bone. That rim of reactive bone is basically known as osteoid, right? Okay.
Yes.
We have close similarity of another bone tumor, that is osteoblastoma. I want you to differentiate osteoid osteoma from osteoblastoma. We already did that. Yes, please.
Yes. Now, osteoblastoma is also the tumor of osteoclast, and but the osteoid osteoma, the size is below 2 centimeter, and in the osteoblastoma is the size is above the 2 centimeter.
We can't hear you.
And yes, and the other differentiation is about the pain that is a result with aspirin in osteoid osteoma and is not resolved with aspirin in osteoblastoma. And both of them are
Perfect.
benign and yeah.
Okay, perfect. So first of all, the osteoid osteoma is going to be like small, right? Less than 2 centimeter wide. Osteoblastoma, again, both of them are same. They are benign tumors of your osteoblast, right? And osteoblastoma is going to be greater than 2 centimeter. And aspirin, with the administration of aspirin, you can relieve the pain caused by osteoid osteoma, but pain caused by osteoblastoma cannot be relieved, right? Okay. So our next topic is osteochondroma. So for that, I
Doc,
need yes, please.
is there any difference in the X-ray between these two?
Okay, so
Osteoblastoma.
okay, so like you can just look for the size, right? So on the X-ray, we already discussed that osteoid osteoma is going to be radiolucent in the middle, right? Because you have osteoid matrix there, right? But osteoblastoma, it would be like bigger in size, and you won't be seeing radiolucent cornea. Is that clear?
And I would also like to add in that osteoblastoma will be usually in the vertebrae, whereas the osteoid osteoma will be in the cortex of the long bones.
Okay, so like as Dr. Huda just told us, you can just also note that down. I'm just yes, that's correct. Okay, so osteochondroma. So Dr. Devanshi, can you just please tell us something about osteochondroma? Hello.
Yes, so osteo is bone tumor, chondro is cartilage, and oma is benign tumor.
Okay.
That from name we could identify that much. And
Okay.
usually its score is around the bone. Cartilage always surrounds the bone.
Okay, perfect. So basically in metaphysis, we are going to see that, right? If you have lateral projection of a bony growth, bony tumor, which is covered by your cartilage, that's simply known as osteochondrosarcoma or osteochondroma. Thank you.
Yeah.
We have osteosarcoma. Dr. Daniela, can you just please tell us something about osteosarcoma? Is it a malignant condition or a benign condition first?
It's sarcoma, so it's malignant.
Dr. Daniela.
Yes, can you hear me? Sorry, I've been
Perfect.
having a network
Yes.
issue. Yes. It's
Okay.
sarcoma, so it's malignant.
Perfect. In which location we are going to see this osteosarcoma in the bone?
In the metaphysis of long bones.
Perfect. Can you just tell me some of the specific imaging findings which are like highly specific to osteosarcoma?
Yeah, you see that Codman triangle?
What is Codman triangle?
It's like elevation of what's it called, the periosteum, correct?
Perfect. If you have elevated like periosteum,
Yes, usually
it would
seen like
just form an angle, right? And
yes.
sunburst appearance as well. Perfect.
Yes,
Right?
sunburst, yes.
Okay,
And
that's okay. And what else?
What else do we see specifically? There's what's it called?
Sorry?
I can't. What else? The osteoid producing cells.
Okay. So okay. So can you just tell me some presenting features?
Yeah, yes. So it's usually it's painful.
Okay.
But it's like a painful, like what's it called? A painful mass, or
Okay,
it's also
perfect.
present
There
with
would be
fractures.
painful swelling, perfect, and pathological fractures. Perfect, right?
Yes.
Okay. So our our other tumor which we are going to discuss is giant cell tumor. You have a lot of MCQ on that. So Dr. Dhiraj, can you just please turn on your mic? Dr. Divya.
Yes, sir.
Okay, please. Can you just tell us something about giant cell tumor? Where are we going to find this tumor?
In epiphysis, sir.
Epiphysis, perfect. And what about the X-ray findings?
In the big osteoclasts are formed, giving the appearance of soap bubble.
Okay, so we have soft bubble appearance, right? Okay, can you just please fix your mic? I'm just, the voice is echoing. So, okay, thank you, Dr. Dhiraj. Okay, so is it an aggressive tumor or not?
Yes, sir. It's
Perfect.
local.
Okay, it's locally very aggressive, right? Okay, Dr. Dhiraj Mandal, can you just please turn on your mic?
Yes, sir.
Hello? Can you just please tell us something about Ewing sarcoma?
Yes, sir.
Hello?
Yes, sir.
Ewing sarcoma. Is it a benign or malignant condition? Okay, I think we should just move to next participant. Can you just please close your mic because I'm, hearing my voice again. Hello. Okay, thank you. Dr. Sabira, can you just please turn on your mic?
Yes, sir.
Can you just please tell us something about Ewing sarcoma? Is it a malignant condition or a benign?
It's a malignant condition usually seen in males. And
Perfect.
it's found in the diaphysis of long bones.
Diaphysis, perfect. What's the specific extra finding?
Onion peel, onion skin appearance due to the periosteal reaction.
Perfect. Periosteum is going to lay down more bone, and as a result of that, if you just see a cross sectional, you'll be seeing like onion skin appearance. Perfect. Okay, so you guys are doing so great. I'm so happy with your performance. You guys, everyone know MSK. I'm so happy with that. So, Dr. Harshni, can you just please turn on your mic? Hello,
Yes.
Dr. Harshni.
Yes, can you hear me?
Please tell me something about. Yes, I can hear you. We have a translocation. What's that in Ewing sarcoma?
Yes, it's 1122 translocation.
Perfect. 1122 translocation. That's perfect, right? So, Dr. Harshni, can you just tell me something about chondroma and chondrosarcoma? How do we differentiate chondroma and chondrosarcoma? We have some common features of them and some of the yes. What is chondroma?
Chondroma is a benign tumor of the cartilage, which usually arises from the medulla of the small bones, like
Perfect.
hand. Chondrosarcoma, it arises from the axial skeleton.
Okay, and it's a malignant condition, sarcoma, right?
Yes, chondrosarcoma is a malignant condition, and it's a malignant cartilage from the which forms a tumor, and it also arises from the.
Okay, perfect. Okay, so our next participant is going to be Dr. Ilma. Dr. Ilma, can you just please tell us something about osteoarthritis? What is osteoarthritis? In which age group we are going to see it? Hello?
Yes, osteoarthritis is a wear and tear arthritis. So you see in elderly patients, you see in obese patients, so obesity is a risk factor.
Okay, why do obesity and trauma is risk factor?
Why it's obesity a risk factor? Because there is more weight on the more weight is transferred to the joint.
Can I say that obesity and trauma would accelerate the process of wear and tear?
Yes.
Okay, perfect. Thank you so much. Dr. ERDOO. Okay, I don't know how to pronounce your name. Can you just please turn on your mic?
Yes, doctor.
Okay, thank you. So, can you just tell me which joints are going to be involved in osteoarthritis?
Usually
what are the commonly involved joints?
The distal interphalangeal.
Okay.
Interphalangeal joint.
Perfect. Distal interphalangeal. What about proximal interphalangeal?
Yes, proximal interphalangeal joints.
Perfect.
Usually the articular cartilage there will be damaged, so you have what you call the joint mice when you look.
Okay, perfect. Okay.
Also, there could be osteophytes as a result of a reactive contact.
Okay. So as we discussed. Perfect. So as Dr. Told us that it's a wear and tear disease. So what happens? The articular cartilage can sometimes, the fragments can move inside the joint space, which are going to be called as joint mice. And furthermore, we are going to see hibernation of the bone. If you do not have articular cartilage, bone will rub against bone, which can lead to reactive bone formation. That is a spike-like appearance, osteophyte formation, right? And once we have osteophyte formation in DIP and PIP, they would resemble some nodes, right? Which are basically called as Hibberdon and Bouchard nodes. Hibberdon in DIP and Bouchard nodes in PIP. Is that clear?
Yes, doctor.
Okay. Yes. Okay, perfect. Okay, last question, Dr. E. Okay, I can't pronounce your name. EUCHARIA. Okay. Okay,
Eukarya.
eukarya. Okay, thank you so much. Okay, eukarya. Can you just please tell me that if a person is using joint, if you have an individual osteoarthritis, if he's using his joint, like at the end of day, would the condition be worsened or it would be like fine?
So with use, it's going to be worse. So at the end of the day, when he's sleeping, when he's resting, it should get better.
Okay, perfect. Why? Because it's a wear and tear disease. If you're using it, you're going to see more problems, right?
Yes.
Okay. So, doctor, can you just please tell me about rheumatoid arthritis?
So RA is an autoimmune disease, so it's going to be mostly seen in women.
Okay.
And the hallmark would be the inflammation, which is granulation tissue, which means it has lots of blood supply and also minor fibrils that lead to the contraction. And because of that, it reduces the joint space, and it's called like a panus.
Ankylosing, right? Fusion.
Yeah, panus.
Perfect. We also have a rheumatoid factor. Can you just tell me what is rheumatoid factor?
Rheumatoid factor, that's going to be the IgM against the Fc portion of the IgG.
Perfect. You have a UL MC on that as well. Thank you so much. Dr. Gabriela, can you just please turn on your mic? Hello? Okay, Dr. Hadil, can you just please turn on your mic? Okay. Dr. Judith, can you just please turn on your mic? Hello? Dr. Huda?
Yes, sir.
Please.
I'm here.
Okay, Dr. Judith, can you just please tell me something about what would be the symptoms or the signs which you'll be expecting in an individual with rheumatoid arthritis?
Yeah, they can present with pain, swelling, and morning stiffness. That may
Okay,
last
perfect.
more than 1 hour. Yep.
Okay, can you just tell me something about for example, if we are also going to have rheumatoid nodules. Can you just tell me something about what are rheumatoid nodules?
The nodules,
Mm-hmm.
yeah, they have nodules from
Okay, so they have like a skin nodules, right? Nodules in the skin or even in the visceral organ. You can expect nodules in rheumatoid arthritis. Simply, they are called as rheumatoid nodules, right? So, Dr. Kims, can you just please tell me something about pannus? What is pannus formation? How do we get pannus? Dr. Kims? Hello?
Pannus nodules can occur as a result of inflammation or proliferation of granulation tissues. Yeah.
Okay, perfect. So we have inflammation of synovium. That's important. One of your MCQ, right? So once we have inflammation in turn leads to resolution, in which we are going to have granulation tissue. In granulation tissue, we already know that it's full of blood vessels. You have contractile filaments there, myofibrils, which can cause contraction, and in turn it can lead to a lot of swan neck deformities. If you're pulling off your joints, it would just lead to fusion, ankylosing, and things like that. Is that clear? Hello? Dr. Kinana, can you just please turn on your mic?
Yes, sir.
Hello? Okay. So, Dr. Kinana, can you just please tell me that, for example, if we aspirate the fluid there in a joint in which we have rheumatoid arthritis, so what will we be seeing? Which cells? Which inflammatory cells?
Granulocytes.
Okay, so we'll be seeing neutrophils and high proteins, right?
Yes.
Okay, perfect. Okay, can you just tell me that how this disease can be?
Doctor, can you just repeat? Neutrophils and what?
And high proteins, right? If there is inflammation going on there, so you're going to expect as we know, whenever we have inflammation, so what happens? You have increased permeability of the blood vessels because we want a lot of inflammatory cells to come there. So with that, a lot of serum proteins can also leak out, right? Can you just tell me, Dr. Kinana, that how can one have anemia of chronic disease with having rheumatoid arthritis? Can you just please tell me a little bit?
Yes, so it's an autoimmune disease, so it's inflammation and it's a chronic inflammation. So this will lead to anemia from chronic disease because of because in chronic inflammation there is what was it? Acute phase reactants.
There is hepcidin, right?
Hepcidin, which is an acute phase reactant, which will lead to anemia from chronic disease.
Okay, hepcidin, right? So what would hepcidin? It would sequester all of the iron within the ferritin stores, and in turn, it would lead to anemia of chronic disease, right? Perfect. Yes. So our next topic, which we are going to discuss, is seronegative spondyloarthritis. Yesterday we discussed that. So Dr. Kims, are you here? Dr. Isra, Dr. Huda, can you just please turn on your mic?
Yes.
Okay. Can you just tell me, we have seronegative spondyloarthropathies. What do we mean by seronegative spondyloarthropathies?
No, I'm sorry. I don't know. I don't know.
Did you attend the lecture?
No, I didn't. I wasn't able to attend yesterday's lecture.
Okay. So let me explain that. Seronegative means that the serum is negative for rheumatoid factor. We do not have rheumatoid factor. Seronegative, negative serum for rheumatoid factor. Spondyloarthropathies. This word spondylo means spine. It means you are going to have axial skeleton involved in these arthropathies. What are arthropathies? Pathologies of your joint.
Joints.
Arthro stands for joints, right? So here are a group of pathologies which comes in seronegative spondyloarthropathies. We have ankylosing spondyloarthritis. We know what is ankylosing fusion, spondylospine, arthritis, joints, right? So ankylosing spondyloarthritis, basically it occurs in like spine, in the sarcoiliac joints. And once we have fusion, it would resemble bamboo spine. Remember? Dr. Lemis? Hello, Dr. Lemis, can you just please turn on your mic?
Can I say? Can I say?
Yes, please. Yes, please. You can say.
Yeah, and there is like a bunch of types of seronegative spondyloarthropathy, and then is AS. It's called the ankylosing spondylitis, and the second one is psoriatic arthritis, then reactive arthritis, and then inflammatory bowel disease, IBD.
Okay, and what about Ritter syndrome?
Sorry?
Ritter syndrome.
It's undifferentiated spondyloarthropathy.
Okay, perfect. So, okay, so Dr. Lamis, can you just please tell me that in ankylosing spondyloarthritis, we are going to have bamboo spine. We already discussed due to fusion of vertebra. What else we are going to see? What are the extra-articular manifestations? We discussed it.
The lung disease because of the compression of the lungs.
Aortitis, remembered?
Okay, yeah. That it caused like aneurysm after that.
Yes, and aneurysm in turn can lead to aortic regurgitation, right? So,
yes.
Perfect. So we have Ritter syndrome. So perfect. Dr. Mariam, can you just please tell us what is Ritter syndrome? What three things? What was the mnemonic for that? First of all.
In the Ritter syndrome, we have the conjunctivitis, we have the urethritis, and we have the arthritis. And
perfect.
Can't see, can't pee, and can't climb.
The tree. Perfect, right? So then our last one was psoriatic arthritis. We discussed that in psoriatic arthritis, some like 10% of psoriasis cases, you're going to see an arthritis, which is specifically known as psoriatic arthritis. And it would involve the distal interphalanges, which would resemble just like a sausage, right? So we are going to call it as sausage finger or toes. Is that clear?
Yes, sir.
One question.
Okay. Yes, please.
One question, sir, just.
Yes, please.
Sir, is the reactive arthritis and Ritter syndrome the same thing?
Is the?
Ritter syndrome and reactive arthritis, are they the same thing?
No, reactive arthritis and Ritters are not the same thing, right? So Ritter is like something like different, and the reactive arthritis is like that's different, right?
Okay, because sir, in the first aid, the exact concept that you discussed in the Ritter syndrome is written in the reactive arthritis.
Okay, so you can just confirm that, but reactive. Okay, you are okay. No, they aren't the same thing. I'll just confirm it, right? So let's have 5 minutes of break. Let me just drink a cup of water, and then we'll be discussing our next topics, gout and our skeletal muscles disease. Okay, so we are almost done with the pathology. So let's have 5 minutes of break and see you, right?
Okay, Doc. Thank you very much.
Yes, doctor.
Hello, can you guys hear me? Hello.
Yes, doc.
Yes. Okay. So the like doctor asked a question: reactive arthritis and reader. Basically, like they aren't same things, right? So reactive arthritis is basically a broader term used. Like for example, if you have infection going on, like in the GI, so it can affect your eyes. It can affect your joints as well, right? So it can be, like the readers can be like considered one of the type or a kind of reactive arthritis. Is it clear? But exactly they aren't same things. Like if you have inflammation somewhere else, it can spread to the joint, it can spread to your eye, it can give you like things same as that of reader syndrome, but exactly they aren't same things. Is that clear?
Yes, sir. Thank you so much.
Okay, so let's discuss our next topic, that is gout, right? So for the gout, I need Dr. Muskan to tell us what is gout.
Yes, doctor. So gouts, basically, there is increase in the uric acid, and this uric acid deposits in the joints as a crystal.
Once it's deposited, what would happen next?
Inflammation.
Perfect. How can we get increased uric acid?
We can get increased uric acid. We have some factors such as the excess alcohol or maybe obesity, diabetes, and usually male, they get more affected. And apart from this, we have something else. The pathophysiology is that basically this uric acid, it comes from the metabolism of purine. Yes.
Purine side.
Yes, and we know that purine, it further converts into AMP and then GMP. Yes.
Okay.
And then to hypoxanthine and then uric acid.
Okay.
So, and we have.
Can you just tell me the significance of enzyme HGPRT? What is HGPRT?
Yes, this HGPRT, it's like salvages the adenosine and guanosine via the salvage pathway. So if HGPRT is high, uric acid will be low. If HGPRT is low, uric acid will be high and further lead to gout.
Okay, and what's the syndrome called in which we have defective or X-linked deficiency of HGPRT? Dr. Eukarya, can you just please tell us? Hello?
It's Leach-Nyhan syndrome.
Okay, perfect. Leach-Nyhan syndrome. Okay. So, can you just tell me that, for example, if you have an individual who is having gout, will it be negative birefringence or positive birefringence? And what is negative and positive birefringence? We already discussed it in detail.
Negative birefringence.
Okay. Perfect. So, Dr. Eukarya, can you just tell me what's the concept behind negative birefringence? What is plane polarized light?
I'm not sure, doctor. I just only know it's negative for now.
Okay. So we discussed that we have plane polarized light. What is plane polarized light? Light which is just like, traveling in a single axis. And if it falls on the crystals of uric acid, uric acid monosodium urate, right? So what would happen? It would only allow blue wavelength to reflect once it's placed perpendicular, right? And if it's parallel to the plane polarized light, it would reflect yellow wavelength light, right? So you will be seeing blue whenever you just place it like perpendicular to the plane polarized light, and whenever they are parallel, it would just reflect yellow light, right? So it's known as negative birefringence. We also have positive birefringence in a condition which is known as pseudo gout, which is due to calcium pyrophosphate dihydrate. Can you just tell me, is it positive or negative birefringence? Again, it's positive, right?
Positive.
What do we mean by positive birefringence?
It's positive.
Okay, Dr. Margaret, can you just please tell me what is positive birefringence? If you just place these crystals perpendicular to plane polarized light, which color wavelength are we going to see?
Yellow.
Perfect. And what about parallel placement of these crystals?
Blue.
Blue. Perfect.
Blue.
Perfect. Okay, Dr. Gyanshi, can you just tell us something about dermatomyositis? What the dermatomyositis basically means?
So dermatomyositis means there's inflammation of the muscles, and also there's a skin condition also.
Perfect. Which muscles? Proximal or distal?
Proximal muscles. So
okay.
Apart from that, they have skin conditions like goiter and peppers, and also heliotrophil rash, which is
what
in
is
the eyelids.
heliotrophil rash?
there's a rash in the eyelids. So because
Okay,
of the antibodies, which is anti-Jo1 antibody,
perfect.
and
Okay,
apart from that, dermatomyositis is common among occult malignancies like gastric carcinoma.
perfect. That's perfect, right? Can you just tell me that we are going to have perimysial inflammation or endomysial inflammation?
So in dermatomyositis, it's perimysial inflammation and CD4 cells, T cells involved.
Perfect. CD4. What's the treatment?
So immunosuppression, so you can give glucocorticoids.
Perfect. And what about the serum creatine kinase? Would it be elevated or less?
It's elevated.
Perfect. Okay, Dr. Huda, we have a same condition as that of dermatomyositis, which is known as polymyositis. Can you just differentiate both of these conditions?
So the polymyositis, that's endomysial inflammation. And,
Perfect. Endomysial. What
and
are the
that's
inflammatory cells?
CD8 cells.
Perfect. And do we have skin involvement?
No, there's only proximal muscle
Perfect.
involved.
That's perfect. Okay, Dr. Devanshi, can you just please? Thank you so much. Yes, perfect. Dr. Devanshi, can you just please turn on your mic?
Yes, doctor.
Can you just please tell me something about X-linked muscular dystrophy or the dystrophin gene? We discussed the story. What is dystrophin molecule?
Dystrophin molecule like Duchenne must.
Okay, so we have Duchenne muscular dystrophy as well, which is due to deletion. But X-linked muscular dystrophy is due to mutation. If we have mutation, what would happen? We will be seeing degeneration of the muscles and replacement of these muscles by adipocytes, right?
Sites. Okay. Yes.
Okay, perfect. Okay, so let's just.
There will be
Okay.
defective attachment of the dystrophin protein to the laminal wall. The
Okay.
site wall, yeah.
Okay,
This is-
perfect. So let's discuss something about Duchenne muscular dystrophy. Is it due to mutation or deletion?
That's due to deletion.
Perfect. Duchenne due to deletion. So can you just tell me that what will okay, so again the idea is same. You're going to have like degeneration proximal muscles and replacement by adipocytes. So here we are going to have calf pseudo hypertrophy. Can you guys just tell me what is calf pseudo hypertrophy?
That will be, yeah. That will be
Deposition of fat, I
Duchenne
believe.
Okay. The idea is very
The
simple.
muscle will be degeneration and fill with fat.
In fact, like the idea is simple. If you have, okay, so in, for example, if you have Duchenne muscular dystrophy, the proximal muscles are going to be weakened, right? So this child will be using his distal muscles, right? For example, in order to walk, like for example, his calf. But later in his life, this pathology is going to, shift towards the distal muscles, right? So once the distal muscles are involved, it will be replaced by adipose, which can end in pseudo hypertrophy, right? That is, the calf would be filled of fats, right? Not muscles. That's why it's known as pseudo hypertrophy, right?
Yes.
Is that clear? Okay. So the last two pathology, the simple one, I want Dr. Sabira to please turn on her mic and please tell us something about myasthenia gravis.
Myasthenia gravis, there is presynaptic.
Okay. Perfect. We have antibodies against postsynaptic acetylcholine, right?
Receptors against receptors.
Postsynaptic acetylcholine, right?
Yes.
Okay, perfect. So, and it's associated with thymoma, remember?
Yeah,
Yes, it's associated with thymoma and with exercise. There is with more.
Okay, with more use, what happens to the symptoms?
worsen.
Symptoms would
They
worse, right?
worsen. They worsen.
Perfect. What's the
Worsen.
treatment? Acetylcholine says just dump a lot of acetyl so that they can knock off the antibodies, right?
Yes, lots of acid
Perfect.
will be fine.
Perfect, right? These are the clinical features. Let's discuss our last pathology, that is Lambert-Eaton syndrome. First of all, I want Dr. Daniela to tell me it's closely associated with carcinoma.
Small cell lung cancer.
Perfect. Small cell lung carcinoma. Can you just tell me with use what happens? Would it improve or would it worsen?
It improves opposite of
Okay,
myasthenia gravis. Mhm.
okay, it would improve. Okay, it would improve. Perfect, right? So with this, okay, if you just resect the cancer, sometimes it can, like eliminate this pathology. With this, we have ended our bootcamp session. Hope so you guys enjoyed. It's a kind of revision. Those who are new, I guess a bootcamp session which is held in the end of, like. So hope so you guys enjoyed. We didn't waste a lot of time, by the way, here. Okay, and I'm like so proud of you guys. You guys know each and everything. I'm so happy with that. And for now, I would say just you guys can enjoy. Just have a first off day or catch up day for tomorrow. But just get ready for the assessment in the end, right? So tomorrow at this time, I'll be sharing the assessment, right? So till then, you can just enjoy your time, right? It's a kind of
Thank you so
like
much, Dr.
half day catch up, right? Not full day catch up,
Thanks, doctor.
Thank you so much,
right?
It was really
Okay.
awesome.
Thanks.
Thank you so much. And can
So
you guys
is
just
there
tell me?
lecture tomorrow or just assessment?
Okay, there would be just assessment, and before that, I'll be having like around about 40 to 45 minutes on. I'll be spending on, like pharmacology, right? So it's a kind of mini catch-up day.
Okay, thank you. And what would be timing approximate?
What would be?
Like timing of that lecture, 11 EST or is it different?
Okay, Dr. Hamza and Laiba is going to tell you. Don't worry about that. And are you guys in? Okay, did you guys just took the like today's webinar on research?
Yeah, it was
Yes,
amazing.
Yes, sir. Okay, so like we have decided that we not only will be guiding through that how to do like research. We'll also be like helping you with your first publications. We have Dr. Abdullah, and soon a lot of other crew are going to join. I'm like actively taking interviews of competent researchers out there. I've just reached out a lot of my friends as well, and soon we will be just like like increasing the wing, right? Don't worry about that, and we'll be assigning like specific like mentors to each and every group. The group would comprise of 12 students, and we are going to take things slowly as it was for you guys, because like we want you to have a lot, like at least 2 research publications once you're applying for your match. So do participate in that, and the further information will be shared in the group. That we'll soon start the registration process. Hello, any questions? Hello. Okay.
No,
So
Doc, thank
once
you. Thank
the
you so much.
registration portal is open, you guys can just like register your slot and just wait for the announcement in the group. Thank you so much.
Thank you so much, doctor.
Thank you so much, Dr. Ahmed.
Thank you. Have a nice day. Have a nice day.
You too.
Thank you. Bye bye.
Bye.